Category 2, part of flap is gone. And then 3, the full flap is gone. So what floor do you guys work on? Oh, okay. So I don't know what all dressings you guys have. You probably don't have as much as Remain or CLC, but so basically we're trying to find the appropriate dressing. Trying to go back to kind of using like a primary and secondary if possible. So like you have your adaptic that you can use as a primary or your Mepitel 1. These are the only sizes we carry in the Mepitel 1, which is little. So this could be something you could use like over the category 1 or the 2. I mean, you can use it on the 3, but you would probably end up using way too many. The adaptic would be perfect for like your arm, because you literally just apply it. And then, I use the new ones, it's kind of like goopy. This is the dried out one. So you would just like put that on your arm, and then we're recommending Liafoam for your sponge. And then you would just use Curlex over it. And then if they're walking, or especially if it's like on their arm or leg, usually it's on the arms, you can use Tubie Grip or stopping as you hold the Curlex in place so it doesn't roll down. No Coban. We're also getting away from not using any steri strips or any paper tape or silk tape on new skin tears. And then for like the initial treatment, we're going to use normal saline for the cleaning, not the wound cleanser. That's not going away, it's just because it's been, a lot of people have noticed that some people feel that the wound cleanser burns. There's nothing in it that is supposed to burn. If anything, this picks up bacteria a little bit better, but for the most part, it does the same thing. However, this has, people have said that that burns when it is used. So initial cleaning will be normal, saline, and these get thrown out for 24 hours. You find an appropriate dressing. If you do not have that, then obviously Mepilex with borders. The Mepilex with border is basically a 3-in-1. Most people don't know that this here is your Mepitel one. You got your sponge and then your piece. So obviously simpler to grab this. These are more expensive. These are less expensive, but it's really what you have available. And then the nice thing about these is that they're breathable and you don't even have to cut them to size. They're good to be applied on healthy skin. But for skin tear treatment, what they're recommending is, again, normal saline, find an appropriate dressing that we can keep on for a good solid 5 days. So like no pulling back every day like we usually do. Like on our floors, we would probably have to ask for an order, like don't pull dressing back, because if you have a Mepilex, you know, that sticky part's going to pull the skin back a little bit. Other than that, that's basically about it. Absorbent integrators we still have, but they're not recommended for those, and this is really only if they have like a tiny skin tear, or even if it fits in here, if they have like not a lot of drainage, it'll work, but usually a lot of drainage will seep under, and then these just don't work. And also we have seen where like 5 of these have been applied to something like that, so again, that's why it's like stay away from that if possible. And then I always just tell people, like, if somebody's using like a Hoyer lift or ceiling lift, be careful when you're pulling out that lift pad, because you can do a skin tear or shearing as well.
This is a crash cart scavenger hunt. So I'm just going to ask you a few questions, have you point to where things are located on the crash cart. So let's say your patient needs assistance with breathing. They're still breathing, but you need a little oxygen to get them. Where can we look in here for that? Okay, let's open it. Yes, 4. Okay, so you got your nasal cannula, you got an non-rebreather, you got a hookup for the wall. You also have your tape on here. What if they need a little bit more help with breathing? We're not going to intubate yet, because we don't intubate. We have to let anesthesia do that. But we can help them in other ways. Yep. If your patient doesn't have a pulse, so we want to start CPR. Something that we could use on this very flimsy mattress. Yes. Yep, the backboard, which is on the back of the cart. Very good. So the next step to that is then, do you think your patient needs to be shocked? No? forget it, let it be. Okay, so what I'm looking at here is AED, right? And with that comes the patches. The patches should be on the top of your cart, ready to go. And by that I mean they're already hooked up. A little over a year, almost 2 years ago, we got the Zols with these new patches. And I just wanted to point out to you, Linda, I know you really know this well, but that we do AP placement, one on the front, one on the back. This one on the front is a little bit deceiving. You got this hockey puck, which is going to go right in the center of the chest, right where you'd place your hand. We're not going to put this triangle up on the heart. We're going to put this puck on the middle of the chest. And then it's going to give feedback to the defibrillator and tell us then how well we're doing chest compressions, just like on RQI. Push harder, push faster, slow down, those types of things. Okay, what if you want to start an IV? Where would that stuff be located? Drawer 3? Yep, okay, so you have IV supplies in here, but you need a flush. That would be in a different drawer.
It's in 1 or 2. Well, it's in 1 or 2, but I think it's in 1.
It is in 1, and it's in this back section here. We got nice new
I wonder what those
organization.
things were.
Yeah.
It was laying there
Pharmacy
forever.
worked up, yeah, pharmacy worked on those for us, and it's much more user-friendly. Top of the line drug, most frequently used drug in a code blue situation is,
Up in there.
okay, you'd think it'd be in drawer 1, just kidding. It is in drawer 2 because of how much we need, so this drawer's a little bit bigger. So crash carts travel, right? They don't all just stay in the unit. And 3 main south moves. So it's important to know where it goes. On the back of all the crash carts are maps. I don't have a fancy map, but I did print them off, so we'll look at those quick too.
Okay.
Just so you know, 3 north will stay, ours stays, but know where your crash cart is coming from. Let's look at those real quick. So after hours for you, 3 south, and this is typically the charge nurse directing somebody to bring a crash cart, takes the whole 3rd floor, other than north side, ICU, and dialysis. During the day, bear with me while I flip all these over and try to find it. It'll be the last one I look at.
Always.
No, that's not it. I think they might have printed wrong. Well, during the day, you have all those same things except for cardiology takes everything after pulmonary clinic.
Each one's got 2 sides. Is it on the back?
Yeah, yep.
Hmm.
So you just go to the end of pulmonary clinic during the day.
Okay.
3 South has its own Lucas. 3 North does not. ICU kind of knows in their heads who has Lucases and who doesn't. Those who don't, when the code is called, they are bringing the Lucas.
Okay.
So that's this next part. The Lucas will come on the crash cart like this, or if ICU is bringing it, it'll come in the backpack like this. Please feel free to open it and help us out with it. So you'll open it. The first thing we want is the back forward part. So Linda, if you want to grab that, we're actually going to put it on. Slides nicely. Can I just show her this picture quick? We want it way up in the armpits because the next part attaches to these, and we need it up right on the sternum so we can get compressions. With him, he's not very flexible. I'll just let that. Now, if you want to grab this next part, it's heavy. Be careful. Bring it on over. We're going to straddle it across his legs. So just set it up. So now we're not going to interrupt compressions to put on the Lucas. We're going to do this on our 2-minute pulse checks when the nurses are checking his pulse, looking at his rhythm, and doing that. So we want to be ready. We want to be efficient. We don't want compressions to stop for more than 10 seconds. So let's set that up right. Yep. And then let's turn it on. Because now somebody's still doing compressions, right, manually, and you're just getting ready. It's easiest if you have one person on each side without breaking his arms. He gets a little handsy. we're gonna set this in. And it's easier if one person clicks than the other.
I'll let you go first.
There you go. 1, 2, we're clicked in. So now we're gonna push number 1. We're manually gonna bring down the diaphragm with your hands so it's nice and flush with his chest there. Next, we're gonna check for the xiphoid. What do you think it's called? Xiphoid. There we go. Okay. So we want to be 2 fingers above that, right? And then that's where this black part is. And so then we're ready to go. So let's do 30 and 2. It'll give 30 compressions. Give us a pause so that we can give breaths. So go ahead and push that.
So basically, you get the right side catheter.
It never gets tired. It never goes slower or faster. It's very consistent. And it frees up probably 2 hemodynamic compressions. That's our cue to give our 2 breaths. And you'll start again. Let's say our 2 minutes is up and we want to pause. Go ahead and push pause. If we need to defibrillate, we can defibrillate while this is pumping. Whereas if you had a person, you'd have to, everybody would have to clear. So you can keep doing compressions while you're defibrillating.
So
What happens?
Jake describes it as a pop. I think it's.
Is it a, are you asking me?
All I remember is a pop.
No, I just thought.
For me, it's more of I know
So you have this
on.
on.
Yeah.
So you can feel it slide, you know.
Oh, is it-
And then you go in.
Oh, you call that the hop.
Plate
Yep,
it.
so
Gotcha.
So we don't want the puck to be underneath
Measure
it.
kind of
Oh, sure.
Because it's going to take up room, and this is giving precise compressions. So it's perforated between the triangle and the
Just like a
puck,
regular
and
catheter.
you want to remove that.
Until you get here and you go another inch.
Because you don't need the
And
feedback.
you get here and you know you're in the right place to inflate.
I've always seen it used. Every
Every
sample I see is I never was barcode. I was like, you didn't take care of that. When you need your normal saline, I've got all the bags, the tubing.
Yeah. The diaphragm here is a 1-page use, so that gets taken off and thrown away. There's a second one in the bag. The rest of it can get wiped down with a Santa cloth and stuck back in the backpack and ready for the next use.
Do all the other Lucases have extra batteries nearby?
That's a good question. No, they're all in the ICU.
People are kind of freaked out about that. Initial pushing in type thing.
It should.
It's Heidi's fault she did it.
For those who can't attend the education fair,
Okay.
that's what we're doing it for. Okay, so where are you from?
4B.
Okay, so you have not had this, brother, you went through the gate belt training? And is this it for you, or is she coming with you guys?
She did have another day.
Okay, all right, so you have went through the gate belt, but
Does she need to come here?
Are you guys started yet?
No, we're just starting.
Do you want 4?
Sure.
well, if it's, Heidi says okay.
Do you want to go
Herself. She only has the crash card left, and then she's gone.
Okay, so you guys, well, you're gonna be on TV twice now.
I'm on TV every time. I wish they'd turn it to somebody
They
else.
should give you a little stipend here for your
That's
TV,
The
right?
NCAA is good for college.
There you go. Okay, so just a little history about the Safe Patient Handling Program here at the VA. It started in 2008, and it was because too many staff members were getting injured on the job. And so Tampa is a big research center in Florida, and they do research studies every year. Back in 2001, something like that, they found that a safe lifting limit was 35 pounds, and that was the limit that you could do without getting injured on the job for staff. This year, they're doing 3 studies. The number 1 is how not to catch a falling patient. Too many staff are getting injured on the job when they try to catch these 300-400 pound patients, and here we are, little people, we can't always, we're gonna get hurt, we're gonna get injured. The second research study that they're doing is the use of gait belts. Believe it or not, how simple they are, but they're doing research on it. And I don't remember what the third one is, because it doesn't pertain to us, it's some other initiative. So they came out with a guidance tool in May, and as simple as it is, a lot of VAs across the country do not have gait belts. They took them away because they were being used inappropriately. They were being used to lift people off the floor, lift people out of the chair to see if they could balance, to see if they could walk, and so they were being used inappropriately. So the new guidance tool, they wanted us to go through and tell all staff the new guidance tool and what it entails. So first of all, when you're putting the gait belt on, make sure, and I'm not going to have you guys do this because you've done it a million times, make sure that the grippers go out. If they go in, it's not doing you any good, it's going to slip on through. So make sure that they go out, slip it on through, and you know when you walk with a patient, you usually grip it like this. What they're saying is don't grip it because that's what's getting us into trouble. If they start to fall, we're going to grab them back. You're supposed to hold it like this. It's only to be used for guiding or ambulating and directing, not to be lifting, pulling, anything like that. So like this or like this. Okay? So that is the guidance tool. Very simple. There's pictures here if you don't believe me on how we're supposed to do it. Very simple. Since this whole scenario is about a dementia patient, this was a lift that we thought would be really good. This is our Sarah Steady. It's our non-motorized lift. You have one on 3 main for 400 pounds, and you have one on CLC for 264 pounds. This lift could be used for anybody that can't walk long distances. For instance, a COPD or a CHF, someone that can't stand for long periods of time. They can use this lift to sit on the flippers, and they can just brush their teeth, wash their hair, whatever they need to do. So now since this is a competency skills fair, I'm going to have you hop on the lift. And Brenda, have you used it? Or Linda? Okay, one of you two. I'll have you go around and show her. So you stand up on here, make sure the brakes are locked.
Am I going to stand facing you?
Yep, you're going to stand right on that plate. These are blocked. You don't have to use the sling unless you have core body strength that isn't very strong. Then you can use the strap. It's kind of up to you. So Linda will put your seat down. Undo the brakes. And then Brenda, you can take her for a little walk. You can sit down while we take you to the restroom and you can go brush your teeth. Now you can kind of take a turn and push it. And you can see how easy it is. You don't have to plug it in. It doesn't have a battery. This would also be good for the C-box to use. Steers really well. Yeah. Linda, you want to take her for a swing? And you just wipe it off with happy waves when you're done. Very, yeah.
And that fits under the toilet? Like it'll fit right under the toilet?
Yeah, that slides right in, yeah.
Yeah. And then if you're going to take it to the bathroom, here's your bathroom, Linda. You're just going to bring her right up to the toilet. It's a little easier if it's a toilet because it doesn't have the legs out here. I'm going to have you stand up when Linda puts the brake on. You use this to stand up. So they have to have upper body strength. They have to be able to stand. Flip these up. Go ahead to the toilet. Now you're done. Stand up. We'll wipe you off. Pull up your pants. And then off you go back to your room. So that's kind of an easy one to use. So that's your Sarah Steady. 2 of them. If you guys, maybe they'd be nice also on 4B. I'm not really sure.
4B doesn't really keep anyone who can transfer, so.
Any impaired mobility that.
It's a nursing home
True.
we use, right?
So the other thing, and it's not related to the education fair, but we got, well, EMS ordered these wheelchairs about, you don't have, well, I'll get to do that. They ordered these wheelchairs about 8 years ago, and they said, and they've been kept in storage. They wanted to keep them in storage until new ER, lobby, everything got under construction was done. Now they brought them out, and they want us to evaluate them to see if we like them or not. There's stacks of chairs because we thought it would take up less space in the lobby because they stack into each other and stick with wheelchairs.
Brenda, I'm going to have you untie one shoe, okay?
Untie one.
And your shoelace, yep.
I was going to say, usually one is always on top.
Okay, so I'm going to give you guys a set of instructions. I want you guys to follow them to the best of your ability, okay? First of all, you're going to put on your brown gloves. Then you're gonna put on your glasses that you have in front of you there. Then you're gonna fill up your pill box with the Seroquel and lisinopril that you have in front of
He
you.
had his chest.
And then once you get to your pill
They
boxes,
won't stay on.
then once you
now we're
get your
ready to
pill
get
boxes
started.
all filled, you have to take your pills for today.
Watch
Okay?
out.
When you're done with that, then I'll give you some next steps. So go ahead and get your pills filled in your med box.
All seven.
Multiple people working on it.
Yes, all 7.
Because it'll give us a pause to give them.
After you get that done, I want you to
I
tie.
have pills in here.
I want you to tie your shoelaces. Well, that means you didn't take some pills from before. Now what are you gonna do?
Double up.
Emerson's sitting out there.
Did you leave those out from yesterday? Are you sure you took them?
Yes.
So it'll continue to do this cycle until you push pause.
Let's get your shirt on,
Have been up, so we're going to pause.
Rachel.
Wow.
Okay, get that buttoned up. We don't want you to catch a cold.
This can keep going while we shop.
Here, Michelle.
No, otherwise we have to.
Okay, I'm in trouble already.
Okay, make sure you get your shirt buttoned up when you're done with that, okay?
I must not see so good in the video.
What are you doing?
I lost a pill.
Oh, gosh. Well, I gotta take you to the bathroom before lunch, so put your feet up.
Person use.
Okay.
Garbage.
I'm sorry.
Rachel, don't stand up. You stay right there, okay?
You can wash it down with Santa Claus. Santa Claus?
Okay, you stay right here till I get back. Okay, I'll be right back. I gotta go answer a call. Henry's on his light again.
That's it.
Did you get your shirt buttoned?
Nope.
But like I said,
Okay, you gotta do that next. You did it yesterday.
and
Do you need help with your shoes?
you release by these.
I don't know yet,
Is your brief wet?
but not yet. It might be by the end of this exercise. There.
Okay, are you ready?
Yes.
Okay,
I like that.
here we go.
That's all I have for you guys.
Well, thank you. Okay, got that?
Thank you.
Next time, before you go to the bathroom in your brief, you let me know, okay?
I will.
So you don't have another accident.
Here if you want to, but I don't mind signing it. Either, whatever you want. If you want mine. send it to me.
Linda, are you all done? You didn't get your hearing aids in yet.
Oh, Dad, I didn't know I had some.
You put them in yesterday all by yourself.
Thank you guys. Did you guys go to Deb yet?
Where are they?
Okay, you got them in now.
Okay.
Can you hear me?
Oh, the battery must be dead.
Yeah, let me try something else.
Oh, there, that's too loud. Oh. Where's that go back?
Okay, how about that? Is that better? Okay. Okay. Did you get your pill taken for the day?
We'll braille it out.
What day is it?
You're gonna braille it. Okay, okay.
I gotta have some water.
You-
Oh, I got 3 in there.
Okay,
One didn't go in the right place, I guess.
okay. You can take your glasses and your gloves off now. So,
I was guessing that it started on Sunday.
So did I. I tried to braille, I couldn't.
those pill boxes are hard to see, aren't they? Yes, okay. So the glasses that you had on, those reflect someone with cataracts. That's someone with cataracts?
That's what I have to look forward to?
Yeah, yeah.
The second research
The gloves, of course, what could that, arthritis, neuropathy, yes, decreased feeling. How did it feel to be given a bunch of instructions all at once? Do we do that sometimes?
However, when
Yeah.
research study, they found that they needed
How did it feel when I asked if you needed your brief changed in front of everybody?
scenario for this.
When I have my guidance to
Well, and sometimes you're yelling it from one room to the other because that's how loud you have to be. But, so, just some lessons here is that, you know, short, simple instructions, one instruction at a time. To be patient. These pill bottles are very typical of what our veterans get out in the home, which is very unfortunate. I hope that changes at some point. This little cap here, I wanted to point out to you too, this little bookmark. These are the top 10 warning signs of someone that may be getting Alzheimer's or dementia. Thank you for putting those all back for me. And some of these are simple things that we kind of blame on old age, such as you know, difference in problem solving or memory loss, confusion with time or place. Those can all be early signs of dementia or Alzheimer's.
So that's the guidance.
The other fact that I think is really, really sad and interesting is that 1 in 3 seniors dies with Alzheimer's or another type of dementia. So they may not die from the Alzheimer's or the dementia, but they have it when they die. So we could be dealing with decreased circulation, poor vision, poor eyesight, poor hearing, and dementia and memory loss. So just kind of keep that in mind. And you know, my mom is 86, and I took her on a trip to Montana a couple weeks ago, and I wanted to do everything for her. You know, just because I thought it was being helpful. And she looked at me and she said, you know, when you do that for me, it makes me feel like I'm helpless. And I'm like, oh gosh. You know, and here we are, we think we're being helpful, but really we're making them dependent.
And these are veterans that are very proud to begin with.
Yep,
so it's
very,
really
very
different on
proud.
them.
Yep, and that's a generation that's very proud. So these glasses too indicate different types of eye diseases or disorders that some of our veterans have. So you can try any of these on if there's retinal detachment, there's diabetic retinopathy in there, there's glaucoma. Any of those that you want to try on, see what it looks like. And you can pass them around if you need to.
So this is a little bit more difficult.
My mom has macular
Stacy
degeneration.
that you left.
And so, you know, she's always looking out, trying to look out of the corner of her eye or look around that.
Topic for this suicide prevention table is how our bias can be a barrier to suicide prevention and having discussions about suicide. And then a second part is an intervention appropriate for all veterans, no matter their risk level. Do you guys feel comfortable talking about suicide with patients? You're getting there? With the increased requirements for screening, especially with the Columbia at admission and discharge, I think just the more people are doing it, we're kind of forced to become more comfortable with it. So I think that's helped people who were not comfortable before. I can say before I came up to mental health, I avoided the topic as much as possible. That's the truth. When I was in primary care and we had to call patients who were discharged from 4B for any mental health reason, especially suicide, I sat there and I hoped they wouldn't pick up the phone. Maybe I was scared of saying the wrong thing, scared of making the situation worse. I know on inpatient it was always reassuring to know that somebody's coming behind me and will have eyes on that patient and that you know that somebody else is going to be there. But when somebody's at home or going home, that might be the last message they got was one from you, and so you just want to make sure you're not doing further harm. It's important to know that asking about suicide is not going to plant thoughts in anybody's head. Have you ever had an experience with a patient around suicide that you can recall that didn't go well or that went really well?
Especially this last year,
Behavioral emergency.
had a
Please
lot of
respond to
positive
4A,
screenings.
room
Okay.
So it
4A,
just,
30.
being able to have that open conversation,
Behavioral
like Matilda
emergency.
talking about it,
Please respond to
is absolutely normal, and
4A,
it's not
room
taboo. And I
4A,
think the
30.
more comfortable that we are as the healthcare
Behavioral
professional, that the
emergency.
more comfortable they become
Please
and will
respond to
actually
4A,
tell you things
room
versus,
4A,
like, if you just sense this
30.
rigidness and they don't want to speak, so.
Yeah, if it feels like you're checking a box, they're probably not gonna wanna open up to you. I've seen people take the approach, well, I have to ask you this, so let's just do it. And even if the patient maybe would have said yes otherwise, at that point, they're probably not going to reveal, something that happened to them or that they've been thinking about. So definitely approach is important. Have you ever had a patient respond badly to being asked? Maybe they became angry, maybe they laughed at the question. Have you had patients not respond?
Yeah. Oh, yeah.
Do you kind of have a go-to when patients don't take the question seriously?
Yeah, my approach has been, we have some of our discharges, we do a repeat Columbia just to verify, and they'll be, oh, I don't want to answer this, and I already told you at the beginning, and I think just reiterating that suicide is a huge epidemic, and so especially with our veteran population, so we take it very seriously. I care about you, and that's why I'm asking. I want to make sure that you're okay before
Absolutely, yeah,
we
that
take the next step.
we don't want anybody to fall through the cracks, and with this, we ask because we care, absolutely. I think that can kind of change somebody's perspective, and especially sometimes the situation when a person walked into the hospital before they were admitted, maybe they got some devastating news. And so things change, and that's why we do screen so frequently, even within one admission. So I think hearing that can be impactful for veterans. I know sometimes our past experiences with suicide, maybe outside of work, some of our religious beliefs or cultural beliefs can impact how we approach the topic. So it's just important sometimes to kind of reflect on those things before we approach the topic. Brenda was telling us that you guys now kind of have a huddle where you share your intentions of why you're at work every day.
I'm in night shift, so we
okay.
get scolded from a bunch of us that may be true for days. I don't know, but
HM?
I didn't know that was a thing. No.
I mean, I just think it sounds wonderful because, I mean, we all get burnt out, especially with some of our frequent flyers. And I know I pretty much left Remain because I was burnt out on detox patients. And I know that I kind of stopped caring as much as I should have for that their outcome really wasn't important. I just knew that see you in a couple weeks. And just that kind of self-reflection
How
can
good
be.
that you realize that though, because that takes a lot of work too.
It can, and I mean at the VA there's lots of opportunities if you're ever looking for a different position. But yeah, just I guess sometimes we have to stay in our job. So yeah, that self-actualization can help out. So yeah, I looked at like a meta-analysis, and I just want to make sure I cover some of those big points. Education in nursing school, I know I went back for my bachelor's a couple years ago, and it wasn't, suicide, mental health wasn't part of the core curriculum unless you took like a specialized class. So I think nursing schools could be doing a better job with the topic. I know it being a national priority for the VA, we have a lot of information coming in we try to share.
Was the number still at 22 a day?
Nope. So that number has been inaccurate for quite a while, actually. And they separated out the data between active duty veterans, National Guard veterans, and veterans no longer serving. They now say the number is 17 a day for veterans. But
That's excluding active duty.
yep, and National Guard,
And National Guard,
that
right.
would not be eligible for VA care. they try to use different statistics to kind of bring that home, just because to be presenting that information and try to divide it out by veterans and active duty people, it kind of gets lost. But yeah, it's definitely still a problem. We've made small gains, but definitely need to do more. The other thing that was identified was that, so you know somebody is at risk for suicide, what can I do about it? So, I mean, you know what to do on your unit. If somebody's identified at risk who maybe wasn't at the start of your shift, you're comfortable. But an intervention that you could talk to any patient about could be their access to lethal means. Lethal means could be a firearm, poison, to include their medication, suffocation. It could be self-cutting injury. It's really hard to limit somebody's complete access to something that they could stab or cut themselves with at home, something that they could hang themselves with at home. But medications and firearms are two things that definitely we can all make a little bit safer. So safe storage of both of those items is important. Our medications that we prescribe all have the locks on the top, the safeties. And we hand out gun locks to anybody, as many as they want. I think we gave somebody over 25 before. There's a lot of people who have a lot of guns in our catchment area. And that's fine, that's our culture. But so we do things like that. When we know a patient's at high risk for overdose, we give them 7-day supplies of their meds at a time. We encourage everyone to use a lock. And then based on their risk level, we encourage kind of extra steps. Maybe we hope everybody stores their firearm locked with the ammunition separate, but maybe they could give their key to a loved one to hold on to. For the people at highest risk with firearms, we encourage them to temporarily store their firearm off-site. It's important to use the word temporary, that we do identify that hopefully your crisis is limited, and when you're in a better place, you'll be able to manage your own firearms again. With medications, if people have a caregiver or a family member, we ask them to help with medication management for a time being. We do know that suicide crisis is often time limited. The 3 circles are a study of suicide attempt survivors. 25% said that between their impulse and their action was less than 5 minutes. So if, say their firearm is locked, say the key's in the garage, anything to build in some time and distance to interrupt that impulse can save lives. We encourage people to keep a photograph of a loved one, an animal, by their firearm, maybe keep it in their car if their plan was to sit in their car. We encourage people to keep the crisis line number wherever their impulse might be leading them. We know that 80% of people who attempt suicide and live will not go on to die by suicide later, so help is available. People can live a more productive life, I guess, after a suicide attempt. The triangles, the red shows suicide deaths by firearm. 85 to 90% of people who attempt suicide with a firearm will die by that injury. I imagine the other 15 to 10% have some sort of lifelong injury. All other means combined, 5% will die. So if someone chooses almost any other method besides a firearm, there's a much greater chance that they will live. It's not about a political debate, it's just completely about crisis management. When I have a discussion with veterans, I try to take that stance. I give them credit for what they know. They all know firearm safety, they all know firearm storage. They've been trained, and it's something that most people will take a lot of pride in. But it's kind of that crisis management, or times when we're going through rough times, maybe relapsing on alcohol or drugs, or going through a divorce, loss of a loved one, when our rational thinking kind of goes out the window. And I think that somebody asked the question, well, do people get offended? Most people who are in crisis or at risk know they're at risk, and they actually appreciate the help in the conversation.
Because,
Can that
and then I
possibly
keep
be
saying it out loud, and I'm like,
Yeah.
just ignore me.
And then just like a
Yeah.
Hi, Angie. Hi. This is the infant feeding tube system and medication administration for a feeding tube. These are the new feeding tubes that the VA is now placing. Going forward, this is all we'll see. Sanford and Essentia are not on board with this yet, so you may still see the old style. The old style, we used to use the catheter tip syringe. This now is only going to be used for urinary catheters. If you have a catheter tip that you need to use the infant syringe with the attachment. And then you've got your catheter tip. To administer HD medications that need to be crushed, you have to use a closed system for that. So you would open up this bag and you would put your medication in there. You would make sure you have a gown on, goggles on, and double gloving. Then you take this with the Silent Night and you crush with the Silent Night. You take your sterile water and you pull up your sterile water. You insert that right here. You squirt that in, shake, 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 and then you drop back up in the syringe. And then this is our infant device. This actually goes right on here.
The very most important
medication goes right on the top.
And it's the first one, but it's not. We use so much of it, and it's like big box.
This here? Yeah, this is for the balloon.
Yeah.
Yeah.
Okay.
And then this is where your feeding tube would be, so you never have to undo the feeding
The next
tube.
thing I want.
Especially nowadays, it looks like most of the ones that we've had were on continuous feed, just small amounts. And so you just stop, you hold it on the machine, you stop it here, and then you do your medication with your flushes and all that kind of stuff.
What is called a chapel or.
Okay, this stuff here and all the purple stuff is good for 24 hours. You wash very good in your, just with tap water. This is only good for a one-time use. So even if you're only using 30 mils for one medication, this needs to get dumped out and then this recycled.
There's absolutely, there's nothing on the back. You know what that is?
Nope,
So let's go.
they're the same.
What is going to be the policy on the
What do you mean?
after flush?
I know that still, you fill that up, that still stays for 24 hours, but this can't. I know,
Baxter's got a plan.
yeah.
Interesting how that works, isn't
I
it?
mean, that just, I asked that question when they said they were still talking about it, but.
Yeah, and I haven't heard anything come down yet, so.
And then, how often for that use, is that every day? Because we've had conflicting answers on that.
This is not every day because it's closed.
Well,
It's a closed system, so it shouldn't, once it's hooked up to
And
the
if they don't
tube,
answer you, then go
it
ask
should
them.
be good. I've never changed these out.
Okay, well, I mean, we've had a lot of discussion on that, because you change everything up to that every day.
Yeah,
And then that little piece stays for how long?
right.
You know, and we've had, like, some patients that do it at home, they get enough of those for every day.
Oh,
So then it's like, okay, are we supposed to be changing it every day? Or I would think, you know, once every week, or, you know?
yeah,
But nobody seems to know.
no,
Okay.
no,
Well,
I
I'm
don't
pretty
think
super
they,
tired of them.
yeah. I don't think Dana knows either.
I was gonna say, we don't do them in the
Yeah,
ER, so
right.
that's all
We
fine
don't
and good.
feed people?
No, we don't feed any, are you kidding? We don't feed anybody. We don't, we have Kool-Aid, that's all we have down
And
there.
are those tubes gonna be different sizes, or they're just a one size, like big tube,
As
or?
far as I know, this is the device itself that will be inserted.
They're up small.
We have, here we go.
They look like they were pulled a while here than they used to. No, I noticed that, yeah, they did look like they were very small. And so they're like big tubes that were thin size.
Yeah, the Mickey tubes are pretty little.
Obviously with these, again, so they're like you really have to be careful not to plug them up with, so that's all flushing between.
Making sure your pills are crushed.
Yeah. Here to get a couple.
And you know how that is when you crush regular pills and you put them in here and you add your water and you swirl. You go to suck it up, you don't always get everything. It bothers me because you don't get everything. Then you wonder what happens when they're off the feeding tube now, and now they're taking the whole pill orally, and now they're getting more diltiazem than they're used to getting, and, yeah.
Where that's where you have other products.
Yeah.
No, it's not a perfect system, but they're trying.
Okay, so then let's grab this guy.
Looking for one in. So SuperPubic caths are very easy to put in. They're just like putting in any other catheter. You can go on clinical skills, get out the instruction sheet. You look and see what size catheter they're using. You don't need a Curday because obviously there's no prostate there. The thing is, usually I like to have everything set up so when I have my 10 mil syringe and I'm going to remove this, I can proceed to go ahead and getting my sterile gloves on and going ahead and cleansing just like you would any other catheter. The biggest, now Jake, I've never done this before, I don't know if you have, Linda, but I usually don't take the old catheter and look to see how far I should approximately insert the new one, because, you know, which is, it's a good tip too if you're uncertain with it. But one of the things that you want everybody to know, and I, you know, if you've first done them and never done them before, when you first go to insert it, there's almost like a pop, because you're going through layers, and you're not just sliding up the natural big track, so there's like a pop that you feel, and then it pushes easier, so there is some resistance. And then, you know, you can insert the tube until you get here, you go an inch further, inch and a half, and then fill your balloon and you know, tap it down. Some people with SuperPubic like it on their abdomen, some like a leg bag, and you can go ahead and put it on a leg bag. The idea is just so it isn't tugging on that site. If it is where you can't get the catheter at, and that's one difference between SuperPubic catheters and other ones. If you can't get it in, there's a hole there, you know, and the bladder is less likely to continue to distend because it's usually just going to leak through there now until this guy's in there. So, any questions? That's my big spiel.
I'm on 4B. Oh, okay, all right, so you, well, you may
You
cross
still
over.
might have modified diet.
Yeah, you're not too far out of the realm yet then. So this is the second year we will have included information on IDSI because we had lots of nurses with questions and we're getting more familiar with it too. And it's good to have the actual IDSI piece into place now so we can see how it actually works. But what IDSI stands for is International Dysphagia Diet Standardization Initiative. So it's much easier to say IDSI.
Yeah.
But it's global. They have more global definitions. It describes the textures and the liquids of foods and is used for individuals who are in all care settings and in all age groups and for all cultures.
So we've got somebody coming from a skilled nursing facility to inpatient, and let's say they have a minced moist diet. It's going to be the same terminology there as it is with us?
Yes.
Okay.
Yep. And it's taken a while to get, I mean, changes challenging sometimes, but it's coming, I think, with more and more use, and as we talk about it more. So there are 7 levels to IDSI, and we have the written materials, and hopefully the C-Box will have those as well, but these will describe what the different levels are, and we have that posted on the board too, but there is a 0 to 4 for the liquids or the beverages, And then from 3 on to 7 are the solids. We don't have a couple of the textures and liquids here just because, well, we don't have pediatrics in this facility, so we'll never see a level 1 here. I think it's more of an infant formula that's used for GERD. And then we don't use like the level 3, there's like a liquidized one that we don't use. But the common ones that we have, we've got both the crosswalk for the liquids and the solids. So on the left, we've got thin, mildly thick, moderately thick, extremely thick. And that used to be, yes, pudding. Yep, those make more sense in our minds, I think, like you can about picture pudding thick liquid. Well, now it's extremely thick. And it's associated with L4, so L level, and then 4 extremely thick. And the color too, so if you think of green, that might be associated with the extremely thick liquids. You'll probably see more commonly mildly thick and moderately thick here in the hospital. And then the textures, they start out with, so level 4 is pureed, and then a little bit more texture from that is the L5 minced and moist. L6 is soft and bite-sized, and then L7 is the easy to chew. And then a little bit more on the liquids. We have pictures on the board of what it looks like on a spoon. So if you think of mildly thick, moderately thick, and extremely thick, and how it might or might not drip off the spoon. Here's some of the texture knowledge questions. First we go over the textures. Pureed is more smooth. It's blenderized or mashed to a pudding-like texture. There shouldn't be any chewing required. It should be free of lumps. And it's usually eaten with a spoon, and it usually falls off the spoon too. L5 minced and moist is foods have a soft texture, and all foods are minced to no larger than 4 millimeters, or about 1/8 of an inch. And they're moistened with sauces and gravies. They'll usually fit between the tines of a fork. L6, one step up from that. So this one is again, foods are soft, moistened with sauces and gravies. All pieces should be no larger than 1.5 centimeters, or a little bit bigger than 1/2 inch. Hard, stringy, chewy foods are avoided. And if you can think of your fork, just a standard fork is a good measuring tool. So the width of that fork is about the size of the bite-sized, or smaller would be appropriate. And then the easy to chew is L7. So again, no hard, sticky, crunchy foods. They say bones, of course, are avoided. You wouldn't want to be eating those. Those would be too hard. But avoid fruits with high water content, such as watermelon, in that texture. So here are some of the questions now. So the L4 puree diet. What are the key characteristics of food on the L4 diet? And there's more than one answer that's correct.
C, D, E?
This one actually, D and E, so, and also A. So no lumps are found in the food.
So it's smooth texture.
Yep, smooth texture on that one. And D, it falls off a spoon when tilted. And then E, it's usually eaten with a spoon. So I prefer it much better when there's just one answer that's correct, the best one, but we have 3 there. Yeah. And then the minced and moist. How do the pieces of food need to be on a level 5 minced and moist diet? And A is fit between the tines of a fork, B, the size of a fingernail, C, 1 inch, or D, no size restriction. A, yep, that's correct. Fit between the tines of a fork. So there's another measuring tool. So you think of L5 and L6 on your fork. That's kind of a good piece to remember. And then L6. What are the key characteristics of food on the L6 soft and bite-sized? They have foods can be cut with a fork. Chewing is required. Pieces no bigger than 1.5 by 1.5 centimeters. It needs to be needs a knife to be cut, and then E is thin liquids drip from food.
So B.
E is one.
C?
Yes, and there's also, this one's also multiple answers correct, but A, B, and C. So it can be cut with a fork on L6, chewing is required on L6, and pieces no bigger than 1.5 by 1.5 centimeters. So, and then numbers, L7, which of the following items are allowed on an easy-to-chew diet? We've got meatloaf, steak sandwich, steamed broccoli, and then carrots and celery sticks.
Meatloaf.
Yep. Steamed broccoli, yep, and everybody says that too with hesitation because we all know how broccoli can be cooked and
Hard.
can be kind of hard, yeah. If it's cooked nice and tender, and depends on how much of the stock is used too. So if it's cooked nice and soft, then you're okay to use it. And then which of the following would be allowed in an L6 soft and bite size? Carrot sticks, whole hot dog, mac and cheese, or soft bagel? C, mac and cheese. And then which diet or diets could have soft bread? L7, L6, L5, L4. L7, yep, the others don't. Now we've had, in the hospital we don't send up bread on L6 and lower, but at home one might be able to do, say, a slice of bread on an L6. Maybe they're able to cut the crust off and cut it into small pieces. If they can be, if they understand, if the patient and family and the person preparing the food can understand well what's happening, then they might be able to get it just the right size and be able to handle it. True or false, regular ice cream is allowed on L2 or mildly thick? False. Yeah. It's too thin.
It's a thin liquid.
It's a thin liquid, yep. So, and L2 is going to be a mildly thick, but ice cream is too thin. But we do have, do you remember what we have for an option that we could give them?
Do you guys have magic cups?
We do, yes. Yes, magic cups are, they don't melt to a thin liquid. And then the next question, foods on an L5 minced and moist diet should not crumble off a tilted spoon.
True.
That's true, yep. And then this one, last true and false question, nuts, popcorn, carrot sticks, and bacon are not allowed on any IDSI dysphagia diet.
True.
True. That one's an, I like that one, it's an easy one, it's all tough. Tough foods, they're not allowed. And then, what is required on the diet order? Is it, A is solid diet order only, B is liquid diet order only, C is both solids and liquids? It's both. Yep, we need to have both that solid and the liquid to get the correct diet order. And the speech therapist is the one that helps us determine which textures are appropriate because they've been able to evaluate the safety of the swallow and where food goes or doesn't go. And so we take the cues from them, from our speech therapist, to know what to order. We have, if we need to have thickened liquids, we've got the thickener packets of Simply Thick in both the nectar is the pink, I'm sorry, mildly thick.
I was like,
Yep, I'm still transitioning too in my mind. But mildly thick and the moderately thick. If you need extremely thick, you can use 2 packets of the moderately thick to make it extremely thick. And you may have pumps. Down in the kitchen we've got the pumps to distribute the amount of thickener needed. But the packets are pretty easy to use. 1 packet will thicken 4 ounces. So that makes it nice and easy. And we can send them in